Ladies and gentlemen, welcome to the Morrissey Movement. The purpose of this podcast is to discuss and share one aspect of fitness and one aspect of medicine. Being a general surgeon and a garage gym athlete, I have a strong passion for both of these aspects of life. So sit back and enjoy the show. This podcast is for entertainment purposes only. I am in no way forming a patient-doctor relationship. While the aspects discussed in this podcast are medically accurate, you should always discuss with your doctor any questions that you may have about the content. You should always discuss with your doctor before starting any new exercise or dietary changes. What's going on, everybody? Thanks for tuning in to another episode of the Morrissey Movement. I am your host, Dr. Chris Morrissey. Hope everyone's had a good week. We had a pretty good weekend. We started off doing our Christmas stuff early with my wife's family out in western Kansas. Then we just got back today and hosted a foreign exchange student Christmas party at the last minute at our house. So it's been kind of a busy week. But anyway, I want to thank everyone for listening. It looks like I've had about 100 listeners or so, which is awesome. Today is going to be episode 4, and today is going to be called Botox and Bone Density. So we're going to talk about the different aspects of Botox, mainly in the cosmetic sense. I will most likely do another podcast regarding therapeutic Botox for migraines at a different time. Real quick, I wanted to also talk about today's sponsor, which is Rejuve Spa here in Winfield, Kansas. I'm actually the medical director for this spa, so we do a lot of cool things, do a lot of massage, do facials, photofacial therapy. I do a lot of procedures at the spa as well, including Botox. I also do fillers, which I can talk about on a different podcast. Also do something called PRP, which is platelet-rich plasma. I also do sclerotherapy, injecting little spider veins. So we do quite a bit of things down there. So if you're ever in the area, want an awesome massage and or some other cool things, that you can stop on in and you can have this done. So anyway, so again, like I said, I'm going to talk about Botox today and also bone density, and the avenue of bone density that I'm going to cover is talk a little bit about the pathophysiology, and then also talk about how different ways you can improve your bone density. So today I'm going to start off with giving a little bit of background on Botox. So it's been around for quite a while. They've been using it for different things in medicine for years now. So the main mechanism of action of Botox, basically, without getting super geeked out in the biochemistry realm, you have these little end plates at the end of your nerves, which basically what happens is you inject Botox to the area, and the Botox actually does not allow the little chemical entities to happen at these end plates, thus reducing the lines in someone's face and or the effects of the muscle that you are injecting into. So Botox is actually which is a botulinum toxin. The bacteria that this comes from is called Clostridium botulinum. So this is found, actually, you hear about the floppy baby syndrome when babies eat honey. This is one area where you can find this. But anyway, there's 3 main different types of Botox that are injected. One is called Botox, obviously. The other one is called Dysport, and the third one is called Xeomin. So these are the 3 that are available in the United States. So there's different manufacturers. Xeomin is actually made by a company called Merz Pharmaceuticals. Botox is made by Allergan, and Dysport is made by Ipsen Biopharm. So depending on where you are, different people will use different neurotoxins to obtain their effects that they are desired to get. So where I am at the Rejuve Spa, I only use Botox. It's been around the longest. And it works. It does a really good job. So that as far as the chemical names of the difference, the Xeomin is called Inco-botulinum toxin A. Botox is botulinum toxin A, and Dysport is abo-botulinum toxin A. So they're just different chemical isomers The effects are a little bit different. The what's called the LD50, which that is the lethal dose that would kill 50% of the population, is a little bit different. The length of effect is a little bit different. So there's lots of different little properties, but they all in the end have the same effect. So what is it like to go through the entire process of getting screened and then getting Botox? So what happens is a client will come to the spa or wherever else the Botox is injected, and you will get, you'll fill out a questionnaire, which is a typical medical questionnaire asking about blood thinning medications, any history of having Botox before. Different facilities have different forms that they'll have you fill out, but so then you'll meet with the injector and or an esthetician that'll kind of get an idea of what you're looking for, and then based off what you're looking for, then we will formulate a plan collectively and then deliver the Botox to you. So you'll show up to the facility, and then, for instance, myself, I will meet you and we'll sit there and talk, and then we'll decide what we think you need. If you've had it in the past and I've injected you, typically I usually just say, hey, did you like the results? Do you want to change anything? Do we need to go any different areas? And so on. So once we decide our plan, then we formulate how many units we think you need. So there's not really any specific test or scan that can be performed to determine the strength of Botox that you need or the amount of units. It's sort of a guessing game, and also it's helpful if you've had it before and you can tell the injector what you've had, where it was injected, how much, if that's possible. The other thing to consider too, though, is the concentration that it's mixed. Some people dilute their Botox a little bit more than others. I myself make mine a little more concentrated. That was the way I was trained by one of the Allergan trainers. So that is how I inject Botox. So what we do again is we sit there and determine, and Botox is priced per unit. So each unit is a certain dollar amount, anywhere between $12 to $15 a unit. And then typically the way I inject Botox is I do 5-point injections along the forehead, and then I do 5-point injection between the eyes, and then depending on what else you would be desiring, and I'll talk about the different areas here in a few minutes, but we'll determine how many units you need based off of what your outcome is wanting to be. So when you come to the room, we have you lay down in a chair, and then we'll cleanse your face with an alcohol-based cleanser, making sure they're removing all the makeup, making sure there's no areas it looks like to be a local infection or a cellulitis, which would be a contraindication to injecting Botox there. So what I usually do is I'll get a makeup pencil, and then I draw lines basically in the middle of your pupil from the hairline down to almost right above the eyes. I usually inject my Botox in between these areas along the main muscle of the forehead called the frontalis muscle. And then what I do is I typically mark out with the pencil, put little dots of where I'm going to inject, so that way the client can know exactly where the Botox is going to go, and then they kind of get a sense of how it's going to be. So I kind of make a W type pattern along the forehead, alternating from a little bit upper on the forehead to a little bit lower on the forehead. So I do 5-point injection on there, and then I go in between the eyes and make a V type shape. So basically I go kind of above the nose, and then just inside the eyebrow line and a little bit above the eyebrow line, and that is where I do my facial Botox as far as forehead goes. The muscles that you're inhibiting close to the eyes, one's called the procerus and the other ones are called the corrugators. That kind of gives you the frown, and so what we try to do is try to smooth those lines out. And then depending on the amount, the kind of the bare minimum that I would inject anywhere, depending on the strength of the muscles, is 2 units per area. So typically the minimum amount of Botox you would get injected would be 20 units. Some people need 4 units per area, so they would get a total of 20 along the forehead and 20 between the eyes, which would be 40 units. So it kind of depends on your budget and also what you need. Some of the other indications of Botox would be what is called the crow's feet, which is the little lines outside of your eyes. So if you desire having those injected, I'll also do 3-point injection just outside of the eye, and then a little bit above and a little bit below, kind of over on the side of the face, on both sides. You can also do what's called a lip flip, or you can inject along the upper lip to kind of give it a little flare out. You can inject smoker's lines, which, if you purse your lips together and there's a lot of lines over your lips, that's another area that can commonly be injected to try to smooth those areas out. As far as other medical uses of Botox, outside of the cosmetic realm, sometimes people have what's called an esophageal stricture, which is kind of just a little narrowing in the esophagus. So you can get these dilated with a scope and a balloon, but also there's another way you can do it, which is by using Botox. So you would mix a concentration and inject multiple units around the stricture to cause that muscle to relax. Another use in the surgical world is you can do this for a chronic anal fissure. Injecting Botox around this area is an option of treatment if a few other the conservative measures do not work. But anyway, so as far as, again, in the cosmetic world, those are the main uses I use for Botox. I have pretty good success with this. Most clients really like it. And again, you inject once and then you have them come back and you can kind of alter your plan depending on how it goes. So the bad thing about Botox is that there's no real antidote. So once you get injected, if you don't like it, you're kind of stuck with it for 3 months. That is typically the length of time that Botox will last. Some people can get longer out of it. Some people, it doesn't go quite as long. So it just kind of depends on the person's metabolism and a lot of other factors, how much you exercise, any other underlying medical conditions. There was a recent article that I read in the literature earlier this year that actually taking 50 milligrams of zinc orally is supposed to make your Botox last longer. I am unsure of the mechanism of action of this, but I do inform my clients of this. Everything with COVID, it just kind of makes sense to take zinc anyway. So it's definitely not going to hurt anything unless you have some sort of weird zinc overload in your body, which I've actually never seen, but that's just one of the things that you can do to try to make your Botox last longer. And I'm a pretty big stickler on the 3-month rule, because what can happen is if you come in and ask for Botox sooner than you're ready for, you could actually develop a tolerance for Botox. So let's say you dropped $400 or $500 to get around, depending on the price, 40 to 45 units of Botox, and then if you come in way too often and people agree to inject you, then sometimes you may be spending double just to get the same effect because your body gets used to it. It's sort of like when you drink alcohol, you can develop a tolerance, but also you can develop antibodies to Botox, which will basically mean, your body forms an immune response to this. So once your body senses that it's there, it'll attack it and destroy it. So Botox actually stops working on you, which I've heard of before. I've personally never seen it at our facility, but I know it does happen. So that's another thing you kind of got to be careful with. So that's, like I said, I'm a big stickler on not coming in before your 3 months is due. So those are really the main things about Botox I wanted to cover. So again, it's very safe. It's been going on for many years that they've been using it. And like I said, I will also cover therapeutic Botox in a separate lecture or a separate podcast, so to speak. So more to come on that later on, but that's really all that I was kind of mainly planning on talking about. If it's something that you're interested in, feel free to find, if you're in the Winfield area, we'd love to come see you at our Rejuve Spa. Otherwise, go to your local either med spa. Some plastic surgeons or dermatologists will do it in their office as well. Just kind of get a good sense of who you're dealing with, and make sure that they have a good reputation before getting injected with Botox. So that's what I have about Botox. So now we're going to transition to the other part of the discussion, which is on bone density. I'm sure most people have heard of this before, but bone density, or how thick the bones are, so to speak, or the amount of calcium in your bones. That is kind of a big thing, especially more in postmenopausal women, but men can also develop these issues. So one of the big things that you will see is something called osteoporosis, which most people I'm sure have heard of. Osteoporosis is actually the reduction of bone density and is usually diagnosed using a DEXA scan, which DEXA stands for dual energy X-ray absorptivometry. So basically it's to measure the amount of minerals, mostly calcium and phosphorus, that are contained in a certain volume of bone. And then bone density measurements are used to diagnose different conditions. It can be osteoporosis, which is by a large decrease in bone mass. There's also something called osteopenia, which is sort of the go-between. It's not quite there yet, but it's getting close to losing a lot of bone density. So and the higher degree you have of bone density loss increases your risk for fracture. So low bone density can occur in patients treated for cancer. You'll also see this referred to as BMD, or bone mass or bone mineral density is another thing you may see in the literature. So who's at risk for osteoporosis or osteopenia? Not everybody will get this. There's a certain risk factors that can increase the likelihood that a person will have moderate to severe loss of bone mass, including the following. So gender, for one, women are typically at higher risk because they have less bone mass to begin with than men. Women also experience a loss of bone mass after menopause, like I alluded to earlier. As far as race concerns, Asian and Caucasian women, especially those that are small boned structure, are at the highest risk. Family history, so patients with a family history of low bone density mass have a 50 to 85%, depending on what you read, increased risk of developing osteoporosis. Age, most people, men and women, lose about 0.5% of bone mass every year after the age of 50. So depletes slowly, but then again, like if you have some of the other risk factors, this may go faster for you. Lifestyle choices, so poor diet, which lacks calcium and vitamin D, smoking, excessive use of alcohol or caffeine, lack of exercise, which ironically we'll discuss here in a few minutes, can contribute to the loss of bone mass. Certain other medical conditions, hyperthyroidism, or basically your metabolism is ramped up and your thyroid is working too hard. Hyperparathyroidism, which this means you have 4 to 5 little glands called your parathyroid glands, which basically their job in a nutshell is to regulate calcium uptake in your body. These are located on the backside of your thyroid. So if these are working on over time, they can also lead to this as well. And there's something called Cushing's syndrome. There's also certain medications, most commonly prednisone, which is oral steroids, depending on, some people have autoimmune conditions like rheumatoid arthritis or things like this that may warrant having prednisone. Also, phenytoin is another drug that is known to cause this as well. So what will happen is when you get a DEXA scan, you'll get what's called a T-score, which is derived by comparing it to the average score of a healthy 30-year-old person of the same sex and race. So the difference between the normal young score and the patient score is referred to as a standard deviation. So T-scores can fall as low as -1 standard deviation and can still be considered somewhat healthy. Patients with a T-score between -1 and -2.5 are diagnosed with osteopenia and are considered at high risk for osteoporosis. And then patients with T-scores lower than -2.5 are diagnosed with osteoporosis. So for these patients, treatment is usually necessary and includes some medications to help increase bone mass, as well as lifestyle changes and diet. So now I've kind of laid the groundwork for this. So the main reason I chose this is, being a general surgeon, I don't really treat or deal with osteoporosis directly in my practice, but I do believe in exercise, and this is one of the things I feel the slightly older population does not exercise probably as often as the younger population, so which is kind of a sad deal, because some of these things can totally be prevented or possibly at least lessened with proper diet and exercise. So there's a study that actually they kind of did a meta-analysis. It's a systematic review and a meta-analysis on the effect of resistance training on bone mineral density in postmenopausal women with osteoporosis. So they went through and screened a whole bunch of different studies and trials, and so they finally went down to 23 randomized controlled trials that they included in their meta-analysis. So they did a risk bias evaluation, showed that the overall literature quality was above medium. So the meta-analysis showed that compared with a blank control group, the resistance training group had a significant effect on improvement of bone mineral density of the lumbar spine. There's a bunch of numbers which doesn't really matter. The bone mineral density of total hip, bone mineral density of the femoral neck, and also bone mineral density of the greater trochanter, which is kind of the area where the hip meets the thigh, so to speak, if you're unfamiliar with the terminology. The final kind of end game of this study was resistance training is beneficial to maintain the bone mineral density level of postmenopausal women with osteoporosis and can be an important part of exercise therapy for postmenopausal women with osteoporosis. So basically, there's a whole bunch of studies that were summed in one few statements stating that resistance training is great for all people across the board. So there's not really one thing that can increase your bone density better than resistance training. And some people view resistance training as the bodybuilders or CrossFit individuals. However, resistance training, in my mind, the definition of resistance is basically just straining your body against a force more so than just your body weight. So, if you're 75 years old and live at home alone, you could get 2 milk jugs and use this as your weights. You don't have to go to a gym and see all these huge steroid freak individuals, bussing everything out in the weight room, grunting and yelling. You can get a lot of good training in your own home, which I'm a big advocate for. So this is another thing in science that proves that resistance training is good for everybody. And there's another study also. The title is Changes in Spinal Bone Density, Back Muscle Size, and Visceral Adipose Tissue, which is like the fat around your intestines and your guts, following a multi-component exercise program in older men. This is basically a secondary analysis of an 18-month randomized controlled trial. So there was 180 men in this trial. They're anywhere between the ages of 50 and 79, and they are randomized to either exercise or no exercise groups. The exercise groups involved high-intensity progressive resistance training, going around 60 to 85% of their maximum strength on different lifts, with weight-bearing impact exercises for about 3 days a week for 18 months. So their bone mineral density was assessed, as well as their in the L1 through L3, and also the paraspinal and the psoas muscle size and cross-sectional area. So the exercise group resulted in a net gain in back muscle cross-sectional area, but there was no effect on the visceral fat around the muscle and around the organs relative to no exercise. So this indicated that there was a positive change associated with the resistance group and versus the no exercise group. There are no group differences in the muscle bone relationship. So basically, this just again shows that, and this was kind of specifically looking at back muscles, but you get the picture of if you do different strength groups or strength training to different muscle groups, you should get the same effect. So again, I have a big proponent of this in my lifestyle, and I'm also a big advocate for this. So if anybody ever, comes to me asking for advice on this, I definitely, I'll say resistance training all day long. It's, like I said, it's been shown in science that it is good for everybody. So anyway, that is the end of the show for the week. So hopefully everybody enjoyed this. Again, I'm going to try to keep cranking these out every week. I appreciate everybody that's listened. And again, this is an open platform. So if anybody would like anything covered or would like me to answer questions, please feel free to email me at the Morrissey Movement, TheMorrisseyMovement @gmail.com. And I'd be more than happy to address anything on the show. And please also leave a review up to 5 stars, whatever you feel is worthwhile, I would really appreciate that. So thanks again for tuning in. Remember, get up and get moving.